politely, we ask that you enter the full name and credentials of everyone in attendance in the chat box so that we may keep attendance for CME purposes. Evaluation forms were distributed at the sign-in table. Please turn in your comments. They're very important to our planning. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Lubimir has disclosed that she has no relationships with commercial supporters that would be a conflict of interest for this presentation. It is my great pleasure to introduce Dr. Karen Lubimir. She's an assistant professor in the Department of Geriatric Medicine. She's a geriatrician and clinician educator with an interest in health literacy as it impacts health outcomes in culturally diverse elderly populations. She graduated from both the University of Connecticut Schools of Dentistry and Medicine, completed her internal medicine at the University of California in Davis in Sacramento, and did her geriatric fellowship here at the University of Hawaii. She's also done her master's in clinical research at the John A. Burns School of Medicine. She's currently the clerkship director for the required MS4 Geriatric and Palliative Medicine rotation, and clinically she provides care with home-based primary care at the VA. Please join me in welcoming Dr. Karen Lubimir.
Thank you, welcome. Is my voice okay? I'm losing my voice, so you might be lucky to be a shorter talk than originally planned, but welcome today. Full disclosure, we're going to be talking about health risk communication. I am not an expert in health statistics. Dr. Takanaka and I struggled through 1 year of statistics with Dr. James Davis at the University of Hawaii School of Medicine, and I was in his office weekly trying to figure out the statistical analysis that he had us rendering. But I do have a very large interest in risk communication. And that's because, as you'll see, it really impacts people's ability to act on health information, which is something that we want for our patients and caregivers need to make those decisions. So today, we're going to look at 3 objectives I'd like you to be able to complete, and that is defining risk and what's its importance in patient-centered care and shared decision-making. Secondly, describe the challenges as we try to communicate health risks with our patients and their caregivers. And lastly, just give me 2 evidence-based methods that we can use to discuss and provide clear numeric information to our patients and caregivers with which they can make decisions. Now I want to ask you, did anybody take a risk today, sort of weigh the benefits or risks of doing an activity today, sort of as it related to their health? Oh, I bet you did. Did you ride in a car to get here? Or perhaps cross the street, right? So did you use a crosswalk or just run off in the middle of traffic? Or when you got in the vehicle, even if you're the passenger, did you wear your seatbelt today? So we know that seatbelts dramatically reduce death and injury when worn. And those are for front seat and drivers. We have the statistics from the National Transportation and Safety Administration, and they said you'll reduce your risk of death by 45% by wearing a seatbelt, and your risk of serious injury by 50%. That's a lot. This health message got across because back in the 80s, only 11% of people wore seatbelts. By 2019, 91% of all occupants are wearing seatbelts. Unfortunately, 1 in 7 people didn't get the message, and they're still not wearing seatbelts. Hence, we have motor vehicle deaths. So let's define risk a little bit. So if just the noun, taking it out of the Webster's dictionary, it's a situation that involves exposure to danger. In health communication, a little bit different. It's really about the probability of an occurrence or future outcomes. And we talk about this in health risk. So this is an adverse or negative health consequence due to some events, some behavior, disease, or other condition. So let's say the example of obesity. We could use anything. We could use smoking, but let's say obesity's health risks we know are associated with diabetes, joint disease, cardiovascular disease, and some cancers. And then prevention, I guess we can't get that to go down. So my slides. Is there a way to make that? Oh, sorry. Okay, so in prevention, we want people to avoid negative health consequences or negative health risks. So we'll present information that way. Sorry. Oh, there you go. Now I get all the slides. So we really, prevention is talking about decreasing our risks. So the importance of health communication. We want people to make choices not based on fear. Music. But we want them to provide good risk communication, communicate the risks, so then they therefore can make decisions. So we know that patient-centered care is really now, it's not provider-centered care now, it's really patient-centered care is the model that we're working off of. It respects people's experiences, what they value, what they need in their lives at that point, and it helps with the planning, coordination, and the follow-through of care. We know that we get quality care when this is followed. It improves outcomes, decreases costs, you get better resource use, and patients are much more satisfied when their care is centered around that. We even have all models, like think of the VA, we have modules that are just focused around one physician, their group of patients, and all the efforts are based in that direction. Also, preventive care revolves around risk perception. So being able to get people involved in their care means they have to understand what their risks truly are. The next area that's really come up is shared decision-making. When do we use shared decision-making? It's kind of a buzzword in the literature now. Getting a little bit of feedback, sorry. But this is a very dynamic process between the patient and the physician. When is it used? You probably have used it yourself. There are two treatments for the same condition, and they're equitable. Their outcomes same. But there's going to be a risk benefit that you need to look at, and those need to be reviewed so that then a decision can be made. We know that this improves knowledge, care, and communication when we use shared decision making. It decreases unwanted interventions, and you'll see it used a lot with decision making tools that then generate conversations. So like a surgical risk, or what I'm thinking is in oncology literature, we use Adjuvant, which is a online decision tool where people can decide about treatment after they undergo their breast cancer surgeries. Another place you'll see that why you need good risk communication, precision medicine is on the forefront. It's on, again, in the literature rather heavily. People are looking at, oh, can we really hone down this treatment or these therapies or these interventions, even if it's prevention, based on somebody's individual needs or individual characteristics, genetically, molecularly, even at the cellular level. Also consider lifestyle and environmental exposures. Lastly, health information online. There's great sources out there. There's Medline Plus, CDC, FDA, Health Finder, the American Heart Association, all kinds of apps that you can use to really look at risks and communicate risks or have people understand. There's also maybe other sources such as doctors, Twitter, Google, yes, Tumblr, Pinterest, and you kind of smile. What percent of people do you think go online for medical information before they go to their doctor? US adults, what do you think? 20, 50, but more than 90, well, maybe not 90. They say over 50% of US adults first go to the internet for their medical information. They don't call their doctor. Maybe like 10% first go to their doctor. So you will need a way to, they come in, so internet users come in and I have this, I'm not taking lisinopril. I heard it causes lung cancer. And so first thing to do, congratulate them. They are actually, they're reading the literature on that treatment or intervention. They're taking an active interest in their health. That's a good thing. Now, then you need to examine the information that they brought you. Does my internet connection's unstable? And then we need to examine, well, does lisinopril cause lung cancer? In fact, there is a study out there that shows lisinopril use does increase the risk of lung cancer. You take it for 6 years, and your risk increases from 1.2 to 1.6 in 1,000 people. Is that realistic? Is that something that we should act on? So just helping your patient decipher. Well, we know that if we reduce blood pressure in, say, a group of 10,000 people with blood pressure, if we reduce their blood pressure to an acceptable range, we could prevent 3,000 deaths out of 10,000. Versus in the same population, maybe 4 people will die of blood cancer. So taking that information and making it actionable or usable, so really understanding how to communicate that risk that they walk into with, I'm not taking my medicine. So what are some of the challenges in presenting health risks? Well, health literacy was going to be in here. If you know anything about my background, I'm super interested in how people obtain information, how they process it, and then how they act on it. So one of the challenges is health numeracy, even worse statistics for the US population in numeracy than for literacy, and we'll look at that. And then another challenge is actually how do people process risk information and make decisions? Huge challenge. And lastly, delivery format. So let's take each of these. So health numeracy, here's a big definition, so let's go. The degree to which individuals have the capacity to access, process, interpret, communicate, and act on numerical, quantitative, graphical, biostatistical, and probabilistic health information needed to make effective health decisions. How many of your patients can do that? Okay. Maybe 1 out of however many, but this is a large task. Okay? I'm going to pare it down a little bit. Really, it's basic math skills needed for health activities. And these are numeric concepts where they have to calculate or process in order to act on health information that you give them. So this could be as simple as reading the bus schedule or reading the proper time and date on an appointment slip. A little more complex, the timing and dosing and scheduling of medications. Or maybe you ask them to lose a certain percentage of body weight in order to improve their cardiovascular risks. So what's driving the need for higher health numeracy? Oh, whoop, went too many. There we go. What's driving the need? So, trend. We already talked about this. The trend is for patient-centered care. So there's and away from provider-centered care. So there's a public demand for health information. They want to manage and prevent diseases, make medical decisions. We have electronic health records, open access. We have government agencies. We'd like to have good public health messages. We want to change people's behavior. We have an obesity problem. We have teen pregnancy. We have a vaping problem. We still have smoking. We want to disseminate this health information so we have a healthier society. We have technology. It's out there. And we have this very rapid dissemination of the latest research and discoveries so that people can learn about them and they may bring that into you as well. They might not have the skills to interpret that information, and we'll see that a little later. And we have the healthcare industry itself, and we have the ask your doctor, because this is a great new drug. It can help you with whatever else. And so how equipped is the US population to deal with these numeracy requirements? So here's our report card for the math skills of the United States. So periodically, the US Department of Education makes a national assessment of educational progress. Last one that I found was in 2007. And this is of high school, 12th grade. And how did they rank? So about 2% were considered advanced level in their skills. 20% are proficient, but 41% are below basic level, and 37 at the basic level. The last two, the 41 and the 37, they can't convert a decimal to a fraction. How about adults? So those over 18, out of school, one presumed, and 50% of them cannot calculate the tip on their bill at a restaurant. And 20% of college students could not state which risk was higher, 1%, 5%, 10%. One thing we do, as researchers have shown, is that they equate lower numeracy literacy with poorer outcomes or health consequences. Looking at preventive screening in a lower numeracy group, they were found to be less likely to be up to date on their screening, specifically mammography and colon cancer screening. As far as self-management of chronic diseases, having lower numeracy has been associated with having poor anticoagulation control, diabetes control, blood pressure control, and control of their lipids. There's also been shown a delay in seeking actually medical services. And this is a study of up to about 100 patients that within 5 days of admission of an acute MI were asked about their symptoms prior to coming to the hospital. And it was found that the lower numeracy had a much longer delay before they sought actual medical care. And lastly, in asthma patients, it's been looked at, and they're more likely, if they have low numeracy, to use the ER or be admitted to the hospital. So having low numeracy can severely impact health. The next challenge is, how do people process health risk information? I found this fascinating in that we think, oh, we just take the numbers, put them into a little equation, and we'll come up with our answer, and there's our decision. That would be the cognitive or sort of rule-based analytical way of looking at health information, but that's not what happens. When people hear numbers, they intuit or have some emotional experience with the number, and they assign some kind of label or value to that number. It's how they feel about it. It's that gut feeling. Okay, so that's the second way that people process risk information, numeric risk information. And then there's what happens making a decision. There may be a combination of the two, cognition and intuition. And the other thing that happens is they generate a risk perception from this information. They start comparing themselves. Am I average? Am I below average? Am I above average? Where's my risk in this group when I look at all the people with this disease or all the people at risk for this disease? Is it something I should be worrying about? Or is it something I can be relieved about when I find out when my risk perception is put in comparison? Oops, and we're still losing our last line. I'm not sure how to make it go away. So know that risk perception drives beliefs about probability that something's going to happen to them or a negative outcome will happen to them. How likely will it happen to me? And that will drive their health behavior. Let's look a little more at this. So let me give you an example of this where people will have cognitive or intuitive emotions and drive their health decision or drive their decision. So I have 2 examples. Let's just stick with jelly beans. It's lunchtime, so we'll stick with the jelly bean example first. And here's a group of people that are asked, you're going to pick a red jelly bean, and you get $1 if you pick that red jelly bean. And here are 2 different bowls. There was 1 red jelly bean in a bowl of 10 jelly beans. The second bowl had 9 red jelly beans in a bowl of 100 jelly beans. So you can see the percentages. Percent of jelly beans in the first small bowl was 10%, and the second large bowl was 9%. Which ones do you think people picked? They really wanted that $1. What do you think they did? Analytically, 10% is much higher, isn't it? But when you ask what did the people choose, the majority of people, they chose the 100 jelly bean bowl. And why? They just felt like they would have a better chance of getting a red jelly bean and getting their $1. Even though we know cognitively, right, the numbers don't lie. Okay. Now let's look a little bit at another example of surgical options. So in this study, and I'm just going to preface that a lot of the research done on medical decision-making or decision-making is hypothetical. These aren't patients that we're putting in this that are being put in this situation. The health researchers are saying, or decision researchers are saying, okay, now pick, and we're going to look. Oops, we're going to look at that. These are a lot hypothetical. Either they happen online, or they happen, within an office scenario, or one was a hospital cafeteria where they randomly pick people. So again, these are actual decisions at point of care. So here's the surgical option. So they told a group of physicians and patients that they had colon cancer. And if we don't operate, you will die. That was the premise. And here are your two surgical options: surgery 1 and surgery 2. And here are the possible outcomes. Surgery 1 and 2 both had cure without any complications of 80%. The difference was that option 1 had 5 possible complications, each with 1% risk of occurrence. Then lastly, and then surgery 2, you had 2 options. You're successful or it fails, 20% failure, right? So when they asked about the different complications and asked the groups to look at them, most people said, 90% of the people said, I guess, colonoscopy, colostomy, they could live with that. And then in increasing strength, they were okay with the rest of the remaining 4 complications. Now they said to the populations, pick which surgery are you going to have. What do you think they said? I think jelly beans. They actually picked surgery 2. What? These are physicians, these are analysis. I mean, we'd already talked about how bad would it be to have these complications. Why would they pick surgery 2? They had the no cure, the death, the mortality was much higher. But what they said was that the reason they picked option 2 is because they felt like they didn't want to deal with the complications. So that cognitive piece was overridden by that intuitive or gut feeling or emotional piece. Very interesting, yeah? So when our patients make decisions or their caregivers and you're like, the numbers aren't lying. Well, there's something else going into the decision besides just the number. Now, other people have looked at this and they'll say higher numeracy. So if you are more astute with numerical information, you're more likely to combine these two. People with lower numeracy, what do you think that they do? Probably don't look at the analytical as much, and they may look at the gut feeling, or in Hawaiian, na'au, right? They go with their gut, and they make the decision based that way. Other things come into play too. What the emotional state is of the person. Right? The more worried, things like that, they will go with their gut instinct. Okay, that will impact as well. Okay, let's not forget or underestimate the power of the format. There's very persuasive information out there. And we know the celebrity touting whatever makes you better, healthier, happier, live longer, whatever. Yeah. Or the person just wearing a white coat in the advertisement gets people's attention because it implies something, and people may look at that. I don't know if any of you, there's Robert, his name is Robert Darvick. He was the inventor of the artificial heart. And back in 2007, he was in a lot of ads for Lipitor. And he said, for people that are at high risk for having a cardiovascular accident, or not cardiovascular, but having an MI, we can lower your risk by 36% if you take Lipitor. Then there's a tiny little asterisk, right? And right next to that asterisk, it looked at the study. That was a rather large study that 3% of the people taking the placebo had a heart attack, and 2% of the study population who took Lipitor had an MI. Okay, so that 36%, pretty persuasive. The inventor of the artificial heart. Okay, so you can see how it works. The other thing, though, persuasion works also for preventive and screening. So Katie Couric, national personality in broadcast media, had her colonoscopy on television. Does anybody remember that? Yeah, pretty powerful. So her screening colonoscopy. Nancy Reagan had a mastectomy and was very open about that, promoting the idea of having mammograms or routine screenings for breast cancer. The other thing that happens in media headlines is there's a lot of make news, right? They want you to go to their site, they want you to buy their journal, whatever, or subscribe to their service. So they're going to have really great headlines and just draw you in. I mean, I'm thinking of the coronavirus. Anybody know the or not kind of dilemma? Anybody read about that? Do you know about or not? Okay. this replication factor of this is in the coronavirus, just briefly, is there's a statistical analysis like how a disease will spread, a virus will spread within a community that's never been exposed. So your index person, how many people, how many people can they expose and make ill in a population that's never seen this before? And they do it for SARS, MERS, we do it for measles and things like that. So this number came out, and I want to quote you with a gentleman from Harvard. He interpreted that number on Twitter, and he said, that quote was, he said it's a thermonuclear pandemic bad number. Thermonuclear pandemic bad. And he was trained at Harvard in public health research. 16,000 hits on his likes on his Twitter, and then he took it down because that number is fraught with different interpretations, where it's applied, when it's applied. Even the formula is can be highly variable. But it made a panic. Basically, how many masks are still left here at Kuakini? Yeah, boxes of masks. Yeah, okay. so it's out there, right? So media grabbing headlines, don't underestimate that. There's also a powerful bias. We want our health messages to grab people's attention, and then we want it to change their behavior, correct? So there may be some bias when these messages are presented. There's also something called information selectivity. And we see this when there's mixed or different opinions professionally on how to treat or manage something. And so information will be selectively distributed. It's when there's maybe treatment uncertainty. So we need to take that into account. Oops, going here. So this is Dr. Anker. I think she's the director of the healthcare policy and research at Cornell. And she said medicine is not a one-size-fits-all. So why should we be surprised that information is not one-size-fits-all? And so I'm going to talk about methods on how to discuss risks with your patients or others. And just know that whether evidence-based, meaning they've been well-researched, there's a host of other methods out there that are possibilities being formed, controversial, they work in this population, but not that population. So I'm presenting to you what I think are 5, many more, but that have been shown to improve risk communication. And those are plain language, surprise, health literacy, remember my interest, framing, relative risk versus absolute risk versus that NNT, dreaded NNT number needed to treat, frequencies or percentages, and graphics. So let's take each one of these. So using plain language, I'm just going to remind people that health literacy is the ability, as I stated before, somebody's ability to obtain, process, and act on health information. And 1/3 of the US population has low health literacy. 2/3 of geriatric population, 65 and older, have low health literacy. Who's using the healthcare system? Maybe the most after babies, our geriatric population. And most average US adults read at 8th grade level or less. And so when you're going to use an unfamiliar term for them, it's really frightening. It implies higher risk. They made up a whole bunch of words and they showed it to people and they had them rate there on a Likert scale how concerned they were about that, whatever word, medical word or supposed medical word, and people, something they couldn't pronounce or had many syllables was perceived as more risky or frightening. Remember your mother told you don't put it in your mouth or rub it on your body if you can't pronounce it? Yeah, okay, same thing. And then there's emotive words. Be careful about using words that provoke emotion. Mad cow disease. Oh my gosh, doesn't sound horrible. And then lastly, something that's been found is if you use the word syndrome versus disease, maybe people think, syndrome's not so bad. But there's certain syndromes that are definitely fraught with health concerns. Next is, I thought this was humorous as I was reading my slides, different interpretation of common terms. One of those terms being common, or using the word unlikely, or possible, or rare, or infrequent. What does that mean? If I asked you what common was, Maybe you'll say 90%, that's common. Maybe somebody else says 52%, that's common. So everybody may have a different level or tolerance for what those values are. Another thing is labels. This is very interesting. We label a lot of things. Is it good? Is it bad? But when we look at outcomes, or we look at reporting of results, we categorize them by these terms, by labeling things. Unfortunately, people use those labels and will oversimplify the information, and they'll be thinking, oh, that was good or that was bad, and then they may not act on that information accordingly. There's something called interpretive labels, and that's when you label something normal or abnormal or positive or negative. And because the expert is giving that information, people may step back and not be as engaged in the process. That question mark of, does it inhibit integration of that information in the patient's choices? We also know that labels change perceptions, risk perceptions. And those, based on those change risk perceptions, people actually change their behavior. And also, labels are very emotive. They provoke emotion. They're, oh, thank goodness. Or they start to worry and they become anxious. Okay, so let's look at these a little bit more. The one I want to talk about is adding interpretive labels. And I'm going to show you a study where they, online study, and it was a scenario they set up, targeting women of childbearing age. And they asked them to imagine, all these are imaginary. Dr. Zickman Fisher has done a lot of research. He's at the University of Michigan, I believe. He said, okay, they actually obtained 1,600 women, and they said, asked them to participate and said, you're 4 months pregnant. And we want to talk about fetal abnormalities and detection. So they assigned them to one of two groups. And they said either you have a low pretest risk, like 2 in 1,000, or you have a high pretest risk, like over 12 in 1,000 of having a fetal abnormality. Then they asked them some risk perception questions. And then do you want to, how worried were they about this number? What do they think they might want to do about it? And then they said, would you take a screening test? It's going to be a blood test. Again, hypothetical. They're going to get a simulated blood test. And they said yes or no. If you know, you left the study. If you said yes, they then sent back the result of that blood test. And they gave every single woman the same result. It was, your risk has been shown by your blood test to be 5 in 1,000. But when they gave this information, they did it one of 3 ways. They either put no label and they just sent the 5 in 1,000, or they labeled it, your result is positive or negative, or they labeled it normal or abnormal. And then they went back and asked them more risk perception questions and asked them, do you want amniocentesis to further find the study? The reason they picked 5 in 1,000 is because that's the miscarriage rate with having amniocentesis. That's how I came up with that number. So what happened? So when we looking at the bar graph on the right, what they found was when they sent their information to the to the low pretest and the high pretest people with no labels, how many wanted amniocentesis? Well, with no labels, the low pretest risk, now they were told they had 2 in 1,000, now the risk is 5 in 1,000 of having fetal abnormalities. And how many of those wanted? So over 50% wanted amniocentesis at this point. In the high pretest group, it was just under 50%. And they didn't find a difference within the 2 groups, between the 2 groups, hence the p-value. When they actually labeled it as being positive or abnormal, or negative or normal, there was a difference. In those low pretest risk group, they now were more likely to want a amniocentesis versus the high risk. Maybe they felt some sigh of relief if they were rated as normal or positive, negative, and their selection of amniocentesis was lower compared to the other group. So actually they felt that the risk, that same information, but some came labeled and some didn't, and there was a difference in how they selected to go forward in their decision making for amniocentesis. Remember, plain language isn't always clear. So Rudy Giuliani, no matter what you think about him right now, he was the mayor of New York City. And he was told he said, oh great, in 2000 he got his biopsy. He thought he was cancer-free because it was positive. He said, I keep getting that mixed up, that positive negative thing, right? I think the negative is bad and positive is good. Not so simple, right? Here's another one we do all the time. Electronic health record access. We give lab results. And depending on the person's familiarity with their disease, their condition, or they've looked at lab values before, we do two things. So here's a hemoglobin of 10, and that's considered low. Here's your hemoglobin A1C, it's 10. That's high, what? So if you don't have high numeracy and ignore the grams per deciliter and the percentage, this doesn't make much sense, does it? Okay. Let's move on. Framing risk information. People like positive, right? We like the good stuff. We like to gain something from what we do. So what's been found is that when you frame things in the positive, there's a lot more acceptance or actions versus framing things in the negative. And let's look at that, especially regarding treatment decisions. This actually, if anybody, I think it's in economics, and I know in health decision making, it's called frame loss or the prospect theory. I don't know if you have any business majors, but anyway. And it's how you frame, people like to win, they don't really like to lose. But in treatment decisions, presenting something by how well people survive it versus the mortality data will facilitate decisions. Another hypothetical case presented to physicians, patients, and I think they're grad students. And they said, you have lung cancer and you can have radiation or surgery. They looked at survival probabilities and things like that. But when they were presenting the surgical information, they presented it one of two ways. Either you have this surgery has a 10% mortality associated with it, or a 90% survival. So much more likely and more accepted when it was presented as 90% survival, okay? Another way that we see in treatment decisions, and there's a little bit of framing goes on when we present risks as incremental versus the total risk, or added, incremental would be the added risk, and we'll look at that in a minute, but I'm gonna keep going. In targeting prevention behaviors, we know that if there's gain, if the outcome is certain, we know that infant cart seats save, lives of children or reduce injury. And we know that physical exercise has been shown that there's something to gain from that, if they're healthier, avoiding the risks of cardiovascular disease, diabetes, strokes, that we frame it that way, people are more likely to act on that information. In targeting preventive behaviors, if the outcome is less certain or there's an uncertain risk associated with it, if it's framed as a loss, in other words, if I don't do something bad could happen to me, that would be a loss. People are more accepting. So mammography is one of those things. If I get mammography, it's not, where's the gain in that? No, there's actually maybe a risk if I don't get mammography. I won't know. I could have acted on that cancer, or I could have relief from that information. Yeah. Another framing of a risk, gain and loss, would be looking at smoking. So a gain statement for quitting smoking would be, you'll live longer if you quit smoking, versus if you'll have a shorter life if you don't quit smoking. So it's a gain, I'm gonna have a longer life, versus I'm gonna have a shorter life, so a loss. Here's the added framing if you're going to look at incremental risk and adding. So this is a study looking at using tamoxifen for prevention of breast cancer. And we know that tamoxifen has lots of side effects in so menopause, cardiovascular risks. But they wanted to pick something that was less scary, let's say, and potentially correctable. So in this study, they framed it by showing cataract risk of getting a cataract if you took tamoxifen. So they did a total risk presentation. So risk of having a cataract without tamoxifen is 9.5%, in this 100-woman population, versus if you took tamoxifen on the next, in that dual next icon array, it was 11.3 women will get cataracts if they take tamoxifen. People had to go back and forth and decide and do addition and some numeric calculation, versus if they framed it by the baseline risk, which is the 9.5, and then the icon summary on the right shows that the incremental risk that was added to their baseline risk was now 1.8 incremental risk increase of cataracts. And what happened here is that people understood this small incremental increase and were more likely to make a health decision based on that, versus trying to compare to different total and then, okay, I'm adding it, and become much more complex and difficult decision making. Let's move on. Okay, so communicating risk reduction. How do we do that? So here comes the numbers, right? Everybody ready? We're going to do a little review of statistics, very basic statistics, but here we go. Your risk of another heart attack is 20% over the next 10 years, but it's okay, we got a new drug. Okay, so how am I going to communicate that to the patient? So I might say, by taking this medication, it can reduce your risk of another heart attack over the next 10 years, give a time frame. And here's how are you going to say it? What's proper? I can say it's going to reduce your risk to 15%. It's going to reduce your risk from 20 to over 100 to 15 over 100. It can reduce your risk by 5%. Reduce your risk by 5 in 100. Reduce your risk by 25%, or if I give this drug to 20 of my patients with the exact same risk as you, I'm going to prevent one heart attack. They're all correct. They're all correct. So what's the best way to talk to your patient about it? I'm going to nix the bottom one. That's number needed to treat if you recognize it. Yeah, and yeah, not helpful. It's my last part in research. So let's present risk, relative or absolute. What do we know about relative risk? Just the definition is it's basic. It just compares risk between two groups, and it's usually expressed as a ratio, risk ratio. And it tells you nothing about your chances of getting the event happening to you. And the equation or the formula for it is the probability or percent of an event happening in an exposed group versus the probability or percentage, based in percentage, of the event happening in an unexposed group. Okay. Absolute risk, on the other hand, is the chance of that event actually happening. And the equation for that is the number of events in a group over the total number of people in that group. So say your risk of getting Alzheimer's is 26% out of 100. So number needed to treat. That's the equation for that is 1 over the absolute risk reduction. Okay, so we're math. And really, research is showing this is not a helpful number to people. It's not personal. I mean, unless you're talking about your whole extended family, my tutu, this, that, then maybe helpful if you're using one small group. And it's not influential in decision making. I'm actually not going to discuss it for that reason. It's not one of the evidence-based ways to provide risk information to help your patients. So relative risk, let's use an example. So this, you're going to the pool. There's two pools. There's a kiddie pool and there's an adult pool. And if you went in the kiddie pool, unfortunately, you had a 12.9% risk of getting Geriatric. And if you went in the adult pool, your risk was only 3.9%. So going to our formula, the relative risk is the risk of the exposed group, the kiddie pool group, versus the unexposed group, that's the people in the adult pool, of getting Geriatric. And it's expressed as this ratio. And you come out with a relative risk of 3.3, and meaning that your risk, if you went in the kiddie pool, the exposed group, you had a 3.3 times greater chance of people that didn't go in the kiddie pool. Okay. So relative risk, reducing risk, so talking to be very important. Most of the information that we give people, especially about treatments, is about, or risk behavior reduction, is about reducing their risk. So let's look at that. I have a breast I don't know what happened to my, oh, there we go. We have a breast cancer prevention trial for drug W. Sorry, my animation got a little mixed up. We enrolled 200 people. 100 people went in the placebo group, and that's our control. 100 people went and started taking drug W. The outcome for the control group is that 2 out of 100 get breast cancer. That's our baseline risk. In the treatment group, wow, only 1 out of 100 got breast cancer. So the risk reduction by taking drug W, there's an absolute risk reduction that went from 2% control to minus the 1%. So your absolute risk reduction was 1%, right? And that's the difference in outcomes between the two groups. Relative risk reduction, oh, I forgot I had this little guy, is based on 1%, which is the exposed group, divided by the baseline risk, and that's a 50% reduction. Can you see our Dr. Jarvis touting his Lipitor, right? The actual risk reduction in that group was 1%, absolute risk reduction. What did he tout on television and the ads? Over 30% risk reduction in your cardiovascular events. So the relative risk reduction is an estimate of the baseline risk that's removed if you're exposed by taking or started taking drug W. Now let's go back to the CDC, because I'm not trying to call them out, but in their seatbelt use, where we had the information earlier that we have this reduced risk of death by 45%, and we cut risk of serious injury by 50%. By the way, light trucks, maybe you drive a light truck, the risk reduction is higher. It's like 60% reduced death by wearing a seatbelt, just FYI. Anyway, so where did this information come from? In a study of 200 fatal motor vehicle accidents, they found that 20 out of 100 deaths occurred, or 20%, in unrestrained drivers, and 11 or out of 100, or 11%, in the restrained drivers. So let's just start the math, and that's absolute risk reduction is 20 minus 11. It's actually a 9% absolute risk reduction, versus the relative risk reduction is what's reported on the webpage, which is 45%, and using the formula there. But we know it saves lives, hence using that other, remember, our behavior message, we want to grab people's attention and we want them to change behaviors. Okay, how about frequencies and percentages? Well, people's perception of risks differs by which one that we use. Frequencies are predicted, so frequencies is out of X, right, 100, 1,000, and it's perceived as a higher risk. So 10 out of 100 versus getting a percentage. Percentages are felt more abstract, not so worrisome. This really doesn't seem like people. That 100, you could maybe think of 100 people, but 10%, what does that really look like? And so people are less likely to respond to percentages, especially when they're low. Frequencies, remember, X out of 100 or X out of 1,000, they're better understood. Patients are more satisfied when you give them that formula. So better to say every year, 10 out of 100 people who have pre-diabetes go on to develop diabetes, versus your chance of getting diabetes is 10%. So a little bit different, personalizes it a little bit. One thing to remember though, even using frequencies, people don't always understand the difference. One out of 10, 1 out of 100, 1 out of 1,000. In fact, when I guess it was college, I'm not sure it was college, but a group of adults was asked and they couldn't tell which was a higher risk of getting the disease, yeah? 1 in 10 versus 1 in 100 versus 1 in 1,000, maybe up to 25% of them not figure out what that differentiation was. One thing though, if you're using multiple risks, just use one, frequency or percentage. Pick one and stay with that. Much better understood. Okay, we're getting to the end. So graphics and visuals. Anybody know where this is? It's just there at Hiptix. What? No, yeah, campus, the Korean Cultural Center. Okay, I love that. Anyway, so graphics and visuals, they work. That's the take. They really work. They drive home the message, especially for people who have low numeracy. The benefits have been shown, multiple studies, improve accuracy when you ask them to feed back the risk information they obtained. The comprehension level goes up. They're very useful in decision aids because they actually are an adjunct to conversations. They can kind of start the conversation off pointing diagrams, using diagrams. And the numeracy burden is much, much lower. Other thing, formats, icon arrays, or also called pictographs, bar graphs, line displays, or pie charts. I'm not going to touch on pie charts, but I will talk about icon arrays or pictographs. Individuals, they love it. Love these little people. They just are very, very positive rating when we show icons, especially when they have people figures. They help reduce bias. There's no denominator neglect. I don't know how many people are here, what, 1,000? I didn't count this one. But either they're depicted out of 100 or 1,000 or some other number. They help with framing effects, reduce the effect of framing effects, positive or negative, very visual. And they also reduce the anecdotal influences. They show frequency, not probability, right? Because X blew men out of however many total men. And you see both the numerator and the denominator in this display. And as I said, much more personal, especially if you use people. They also can show this, some people call it binary choice, or this pictograph display is very useful in displaying incremental risk. We looked at it before with the cataracts and tamoxifen, so I won't belabor it here, but just show that when looking at survival data, what's the benefit of adding a treatment, or you could use risk of adding a treatment to this baseline risk. Very well received. Also, we see them, people lined up and there's a visual, but here's one that is a kind of a random arrangement. And they actually help feel, it gives a little bit more of a gestalt of the whole situation that, oh, wait, there are all those men and now they're missing, they took tirazosin, their BPH symptoms are better. And actually people think that it helps them have a concept of the fact that there's a chance involved. And then, oh, I'm going to remove some of that possibility. This one is this kind of part to whole where things are shaded. Also, not really numeracy is limited here, or limited need for numeracy, because the shading effects help people make decisions and see the difference between the two therapies, in this case, balloon angioplasty or bypass surgery. Here's an icon array and decisions. I picked this because I liked it, and I gave a source for this as well, and looking at how to discuss cardiopulmonary resuscitation in older people who have an event in the hospital and who survives 1 year later. Another one here is used in pulse discussions, which actually is a combination, because it's not only showing frequency, but it's also showing the percentage in each group. So, and nicely displayed by age as well. So you can see who gets to go home and who actually survives long enough and actually ends up in a nursing home. What's not displayed in the one previously is how many are neurologically intact that survive of that last low 10. What about bar graphs? Well, here's some of the strengths. Depicting relative risk, really nice to depict the risks across, in this case on the left, different possibilities or outcomes in diseases for somebody. And then on the right, this is making comparisons of therapy, different therapies for breast cancer survivors. Careful, so bar graphs can also be used to persuade, or they can compare. So you can see the y-axis in the left, and so I'm showing out of 10% what their risk would be, right? So it really exaggerates that there's this huge difference. But when we put on the scale of 100% on the y-axis instead, the risk really hasn't changed that much. So they can be used either way, and be cautious when using or when borrowing from literature or reviewing the literature to present to patients. Well, I had to put this one in standard toothpaste, okay? So I trained as a dentist, and February is National Dental Children's Health Month. just so you know. So it's February, so here's the toothpaste. So here's the bar graph. Really, it's not very helpful, is it? We've stacked part to whole and called a stacked bar graph. I'm having a hard time interpreting it. And maybe the range, if they had made it shorter, we would have seen, like back in our bar graph, the differences in using different toothpaste. So, sorry. But so not always helpful, I should say. And then, so when picking, look at actually what the range that they're displaying. They're trying to show all 5,000 users. They might have been better showing fewer number of users in this study. How about line displays? Well, this is happens to be for a survival graph for Crawford's disease, which is an imaginary disease. And when they asked viewers to look at this and make some projections, really numerical data wasn't looked at all. They just looked at how far apart are all those little lines on this far end here. You know, how far apart. But if you notice the difference in the two scales, that one's out of 15 years and one's out of only 5 years on the lower. So the visualization is a little bit harder versus more apparent on this side. Make sure that you are using the same time frames if you're going to compare multiple treatments for survival with a recommendation. I threw this in. This is not evidence-based yet, but it goes back to the thought of we give patients laboratory information, or they can look it up on the electronic health record and it's in a vacuum, right? There's no context around it. So Zeichman Fisher has been looking at how can we use some kind of line display? When should somebody be anxious? Should they be calling the doctor? So you send your lab results off, you mail them off, you might have a little note, looks good, or please call me, or something like that. Or they go on the HR and they look up and they're like, what does this mean? And what he said, or what he's looking at is, if I put a harm anchor, in other words, at what point, and you're going to look at the bottom one here, would a physician get worried about this value for this? This happens to be creatinine. I don't know about you, but 3 seems a little high. I may be worried a little sooner, but anyway, he did this based on working with physicians and picking numbers. But as a way to help and think about it, you could actually, he suggests in one of his podcasts, that you could actually draw this kind of a display for your patient when you're giving information. Because this is available, this is experimental right now, is if you had a harm, you know, this is where you were before, but giving them some information. Because once they have this harm, once they had this harm anchor, people could either relax, depending on how close they were to it, or they could give a call in, or you can make an information. Again, if you're not interacting with them, or they're not interacting with a professional to interpret the information, they may need some kind of parameter versus just a number on a page with high, low next to it, and no other context. So, at the end, oh, just on time. So in summary, health risk communication, it's essential. We're asking people to make decisions all the time. You're making decisions. You buckled up your seatbelts, where you crossed in the crosswalk. You washed your hands for the whole ABC song so that you could get all the germs off today. But you did something. So it's important, and we take risks into considerations for our own health, for our patients' health. We're asking them to make decisions. It's essential to provide patient-centered care and this preventive education. There are challenges. Health numeracy is the largest one probably for the U.S. adult population. People don't get numbers, and they come in all different forms, and they're contrived, or they're used for persuasion or bias. The processing of it and how we make decisions is extremely complex. If it was all analytical, just put it in the computer and spit out the decision at the end. That is one of the problems with decision aids, right? Because they try to figure out how to have these decision aids account for there may be some emotional or intuitive processing going on in making a decision. And that's why the decision aid is not going to replace the physician-patient conversation in making treatment decisions. And then they also know that there's bias and persuasive delivery as people obtain information and what that effect is. So there's some methods that are evidence-based. And as I said, I picked the ones that had the most the most robust findings behind them, and that's using plain language, watching the effect of labeling, looking at the effects of framing, whether positive, negative, gain, or loss. And then please present, don't just present relative risk reduction, also include absolute risk reduction. Be careful in your use of numbers. I would not use number needed to treat. It's not personal, and people have a hard time using it in decision making. Try to use frequencies versus percentages, or just use one. If you've got multiple treatments that you're looking at, you stay in one form. If you're using frequencies, don't change the denominator. Everybody has to be the same, right? Has to be 1 out of 100, 1 out of 1,000. Keep it all the same. And then graphics, probably the top two that are accepted and have increased accuracy and comprehension would be icons and bars. Bar graphs, sorry. So thank you. Any questions? Or, yes.
Yeah, common, the definition of an absolute risk and absolute outcomes, I think is, I don't know if you can call it absolute. Human beings are diverse, and the situations are diverse. And looking at your situation, between the surgery, one surgery, it depends on your circumstances, okay? You may have a 4% additional survival with the first procedure. What if you're homeless? If you have a small bowel obstruction, if you have diarrhea, if you have infections, if you're homeless, that devastating. And maybe for them, the best solution is solution 2. When you don't have this issue. Other issues, diabetes, you can tell them, okay, these are your percentages. You do this. But what happens if your diabetic runs out of money at the end of the month and they can't afford food? They gotta go, to the food bank, and they take whatever they can get. So it's not absolute. You have to tailor this to the individual patient. It's not always clear-cut choice.
So in personalized medicine, I mean, that's where we talk about that these are starting places that you have to understand the person, the environment, the lifestyle when you go into decision making. That's why risk communication is so important, taking into account the individual. And like the Dr. Acker had said, it's not one size fits all. I mean, medicine isn't like that, just as you're pointing out. Circumstances are highly variable, and same thing with risks. Thank you. Anybody else?